Does high-dose vitamin D improve outcomes for metastatic colorectal cancer? After out-of-hospital cardiac arrest, how long should we be cooling patients? Do iron supplements plus malaria prevention improve cognitive outcomes among infants in Malawi? This and so much more on today's JAMA Editor's Summary. Hello, welcome to our listeners all around the world. Today is August 7th, 2026. I'm Dr. Linda Brubaker, JAMA Deputy Editor, sitting in for Dr. Bibbins Domingo, JAMA's Editor-in-Chief. Today I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hi Preeti, let's take a look at some of the newest research published in JAMA.
Hi Linda. First up is the Solaris randomized clinical trial, which is a phase 3 trial by Dr. Ng and colleagues from the Alliance for Clinical Trials in Oncology. The investigators focused on high-dose vitamin D3 for patients who are previously untreated for metastatic colorectal cancer. Now, preclinical data supports the biologic basis for vitamin D's role as a potential anti-neoplastic agent in colorectal cancer, and several recent studies have produced signals that vitamin D supplementation could improve outcomes among this patient population. This double-blind phase 3 trial enrolled 455 patients from across the U.S. with previously untreated metastatic colorectal cancer. Patients received chemotherapy plus bevacizumab, along with either high-dose or standard-dose vitamin D3. The primary outcome, median progression-free survival, was 11.8 months with high-dose vitamin D3 and 10.3 months with standard-dose vitamin D3. That difference was not enough to show any meaningful clinical benefit of high-dose vitamin D3. Overall response rates to treatment, survival, and toxicity, as well as side effects, were also similar in both groups. In a pre-specified subgroup analysis, there was a significant interaction for patients with left-sided tumors. Although those participants who received high-dose vitamin D3 did have a significant improvement in progression-free survival, the authors emphasize that this finding is exploratory and requires further investigation. So based on these results, high-dose vitamin D3 should not be added routinely for patients receiving treatment for metastatic colorectal cancer.
Preeti, I think the nuances in the secondary analysis and discussion make it sound like this won't be the last time we will hear about vitamin D and colorectal cancer.
Absolutely, Linda. I think there's more to come in this story. Moving on to the next original investigation, which addresses therapeutic hypothermia after out-of-hospital cardiac arrest. Dr. Maurer and colleagues studied how long we should cool these patients in the ICE-CAP trial.
What a great trial name.
Agreed. This adaptive randomized trial enrolled 1,158 patients at 71 U.S. hospitals. Participants were survivors of out-of-hospital cardiac arrest who remained unconscious. The majority, 883, had non-shockable rhythms. Participants were cooled to 33 degrees Celsius within 4 hours of cardiac arrest, and for durations ranging from 6 to 48 hours. The primary outcome was neurologic function at 90 days, measured using a weighted modified Rankin scale score, analyzed using a Bayesian duration response model. The key finding of the ICE-CAP trial was that longer cooling did not improve neurologic outcomes. Among patients in the non-shockable rhythm group, the posterior probability that 6 hours was the shortest duration achieving the best observed outcome was 0.51, and the results were similar among patients in the group with shockable rhythms. Secondary outcomes and mortality also did not differ across cooling durations. The clinical takeaway of this trial is straightforward. Routinely extending therapeutic hypothermia beyond shorter durations did not improve outcomes.
This is a very practical question in critical care, and it sounds like there may be some interesting sub-studies coming from the ICE-CAP cohort that could help shed more light on this area of evolving evidence to inform clinical practice. Another practical question was studied in southern Malawi. Dr. Firi and colleagues tested whether routine iron and micronutrient supplementation paired with malaria chemoprevention help early child development. The IRMA trial randomized 2,168 infants at 6 months of age, 71% of whom had anemia. Children were randomly assigned to one of 4 groups and either received iron syrup plus malaria chemoprevention, iron-containing micronutrient powders plus malaria chemoprevention alone, or placebo alone for 6 months. The primary outcome, cognitive development measured at 1 year of age, did not differ between groups. The iron interventions increased ferritin, although the prevalence of anemia was not meaningfully reduced. Neither iron supplementation strategy increased malaria risk compared with chemoprevention alone. The investigators concluded that this routine 6-month iron and micronutrient intervention did not improve cognitive outcomes in this setting.
In an accompanying editorial, Dr. Cusick and colleagues say that this trial helps answer an important safety question. Iron, given with malaria chemoprevention, appeared safe here, but it was not enough to produce sustained hematologic or clear early neurodevelopmental benefit. The editorialist's broader point is that iron supplementation alone is unlikely to solve anemia or neurodevelopmental risk in settings shaped by food insecurity, inflammation, and ongoing infection risk. They also emphasize that if neurodevelopment is the outcome of interest, more of these studies must be funded to go years beyond early life.
Preeti, let's move on to a new JAMA research letter. In a 2024 JAMA report, the Tesla investigators reported that selecting patients for endovascular therapy using non-contrast CT alone for patients with acute ischemic stroke and large core infarcts did not lead to a significant improvement in 90-day functional outcomes with thrombectomy. In this research letter, Dr. Zaidat and colleagues reported the 1-year outcomes from the Tesla trial. The longer-term exploratory findings suggest benefit from thrombectomy in carefully selected patients using the simpler CT-based approach. Among 277 patients with 1-year data, mortality was similar at 43.1% versus 46.6% without a statistically significant difference. However, the mean utility-weighted modified Rankin scale score was better with thrombectomy than with medical management alone, 3.65 versus 2.78. Functional independence was 23.6% with thrombectomy versus 6.8% with medical management. Independent ambulation was 35.4% versus 18%, and quality of life scores were better with thrombectomy.
Well, Linda, it sounds like there's some good reasons to further explore this strategy, especially for the management of stroke globally. There were some interesting opinion articles this week. In his viewpoint, Dr. White discusses the regulation or lack thereof for some digital health technologies like wearables and health apps. He explains that consumers may not realize that the health insights they are receiving have not been rigorously evaluated. Dr. White argues that these devices should be held to a higher standard when it comes to verification of data and performance transparency.
And in a new perspective piece on a similar theme, Dr. Kishore and colleagues discuss data from wearable devices in the AI era. They argue that many device-generated measures look clinically meaningful, but still function as results of unknown significance. Their framework is meant to help clinicians decide what belongs in the electronic record and what should guide care and what should stay as contextual information only. JAMA Executive Editor Dr. Kerfman's editor note comments on the regulation of general wellness devices and outlines the current limited framework from the FDA and FTC. Although the current framework may be reasonable for low-risk products, regulation should stay calibrated to actual risk and intended use, especially as AI capabilities expand.
JAMA Plus Trials Editor-in-Chief Dr. Wang and JAMA Senior Statistical Editor Dr. Lewis authored an editorial in which they argue that stopping a trial early is not automatically a flaw. The key is whether the stopping rules were planned, transparent, and scientifically justified, because a well-stopped trial can still make an important contribution. For more great insights on clinical trials, be sure to check out JAMA Plus Trials.
We have a practical and patient-centered JAMA Insights by Dr. Midgard and colleagues about communicating with patients about physical activity. The authors recommend asking permission to discuss activity, emphasize that any movement counts, and focus on realistic goals, self-monitoring, and social support rather than blame. The article includes a table with some great focus points and practical examples for these counseling interventions. In a related JAMA Clinical Reviews podcast, Dr. Coppola discusses this JAMA insights further with co-author Dr. Bricca. Let's listen to a clip.
What kind of advice do you give about the dose and intensity of exercise when you recommend that? And how is that something that we can incorporate into our practice?
In practice, very pragmatically, I think that the optimal dose and intensity is the one that the patient wants to do and can do now and over time. And this is very much in line with the latest message from the WHO guidelines on physical activity and sedentary behavior, where it's clear that they do recommend that every move counts. However, the WHO guidelines on physical activity also highlights that adults should at least perform 150 minutes per week of aerobic, moderate intensity physical activity. And this could be the goal, maybe long-term, from most patients, and not the starting point.
There's also a new review on classic Hodgkin lymphoma by Drs. Patel and Moskovitz. A few takeaways. Classic Hodgkin lymphoma usually presents with subdiaphragmatic lymphadenopathy, and about 30 to 40% of patients have B symptoms, which include systemic symptoms like fevers, drenching sweats, and weight loss. Early-stage disease is treated with chemotherapy, with or without radiotherapy, while advanced-stage disease is usually treated with chemotherapy alone. Brentuximab vedotin, or PD-1 immunotherapy, now has a role in some early-stage unfavorable disease and all advanced-stage disease. Relapsed or refractory disease should prompt evaluation for stem cell transplant. Cure rates approach 90%, but long-term survivors need monitoring for secondary cancers, cardiopulmonary disease, and thyroid dysfunction. Here's more from Dr. Moskovitz from the Related JAMA Clinical Reviews podcast.
And what is the typical presentation of patients with Hodgkin lymphoma?
I'd say the most common presentation is potentially a lump in the neck that someone palpates. Often they may come to the attention of their primary doctor, and this enlarged lymphadenopathy may be considered to be potentially an infection, and they may first get a course of antibiotics. But then typically the lump will persist, and that will lead to a biopsy.
And this week's JAMA patient page presents the therapeutic use of cannabis and cannabinoids. 3 cannabinoid products are FDA approved for chemotherapy-related nausea and vomiting, HIV or AIDS-related weight loss, and rare severe childhood seizure disorders. For most other conditions, including acute and chronic pain, insomnia, and most mental health disorders, evidence is insufficient, and patients should receive counseling about adverse effects, impaired driving, and cannabis use disorder. And in the latest episode of the JAMA Healthy Dialogue podcast, we hear from Dr. Marion Nessel, an influential author on food and food politics, for a candid conversation with host Dr. Derek Angus on the current obesity epidemic. Here's a bit of their discussion.
The famous Lay's potato chip commercial where Bert Lahr held up a potato chip and said, you can't eat just one. That's the whole point. So if food is in front of you, you will eat it. If it's in larger portions, you'll eat the whole portion. We're human. That's how we do things. And people put on weight. And the rest is what we're dealing with, and confronting that and trying to change the environment is very, very difficult and politically impossible, because it requires taking on the food industry. So most efforts to try to do something about obesity blame the individual. It's your fault if you're overweight. Just stop eating so much, as if that were possible in today's environment. And the way I put it is, if you're trying to eat healthfully in today's food environment, you are fighting an entire food system on your own, and they're bigger than you are.
And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Michael Lipnick at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
The script for this podcast was generated with assistance from OpenAI's GPT 5.5 following an editor-developed prompt. The script was then reviewed, edited, and approved by editorial staff. This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.